I'm Brave 150 trial. It is a phase 3 trial of first line etizo with bevacizumab in patient with unresectable hepatocellular cellular carcinoma. So as we know, it is the sixth most common cancer worldwide, and it represents around 5% of new cancers. And though other variety like cholangio, angiosarcoma, and hepatoblastoma are makes other 10% cancers of liver. So it is fourth leading cause of global mortality. Uh, After lung, colorectal, stomach, fourth one is liver. And 90% of liver cancer are HCC. And by 2025, number of cases will increase by 13%. So these are the various risk factors as per geography. So in world, most common causes still viral infections, though it varies from HCV to HBV, then alcohol. These are the further causes. So today I will discuss about the mechanism of immune escape in hepatocellular tumors. So with as in lymph node and vessels, when there is release of cancer cell antigen, then these are presented to dendritic cell, then priming and activation occurs. Then there is infiltration of T cell into tumors. Then there is recognition of cancer cells. Then these cancer cells are killed. It is seen that tumor infiltrating T cells are found in more than 50% of HCC patients. And it has shown that it correlates with PFS. So hepatocellular carcinoma may evade immune checkpoint inhibitors by expressing PD1, PDL1 and CTLA4 and TIM3 and LAG3. As we know that liver is very vascular organ, it is also seen that VEGF-A overexpression is very highly associated with HCC, and it confirms poor prognosis. And it is highly vascular nature is due to vascular endothelial growth factor A, and it induces new angiogenesis and tumor proliferation. And its overexpression confirms poor OS and DFS in HCC. So we'll show the journey of various progresses over the year. In 1970s, after that, we don't have any treatment. Then started chemotherapy with doxorubicin based regime, which is still in, I think, some Ayushman packages. Then in 2007 came the SHARP trial, which has shown the first line benefit of sorafenib. Then came further drugs like further drug tested sunitinib, brivanib, linafenib, then TACE plus sorafenib, then DB TACE plus sorafenib. Then reflect trial has shown lenvatinib as non-inferior. Then came in 2009 nivolumab. Then I am Brave 150 study, which I will show you about etizolizumab and bevacizumab. So in this earlier study, we have seen that single agent checkpoint inhibitors due to immune escape, it has not shown the improved outcome in advanced HCC, which was shown in Checkmate 459 trial, in which median OS was 16.4 months in nivolumab and sorafenib 14.7, and it was not significant. So then came the concept of combining etizolizumab plus bevacizumab, and I will show you the rationale and proof of this concept. So as I have shown you the various mechanisms that earlier, that how this immune escape occurred. So the goal of cancer immunotherapy combination is to create a more favorable environment to maximize the immune system potential to eliminate cancer. And both these drugs, Atizo and bevacizumab, they work as a complementary. As I have shown that HCC overexpresses VEGF, so bevacizumab by inhibiting VEGF, it increases suppression of dendritic cell maturation, which leads to priming and activation of T cell response, so that our it recognizes tumor antigen. Then Atizo, working as complementary, it restores the anti-cancer immunity by T cell mediated uh, cancer cell killing. So it restores. Then bevacizumab also normalizes the tumor vasculature, resulting in increased infiltration of tumor cell. It recruits. Then bevacizumab also decreases the activity of Tregs, and it reprograms the tumor microenvironment, which helps in reprogramming the immune system. So based on this concept, this phase 3 trial was done. I'm Brave 150. It is phase 3 trial of first line Atizo plus bevacizumab in patient with unresectable hepatocellular carcinoma. In this trial, locally advanced and metastatic patients were taken. It was first line trial. There were 501 patients. They were stratified based on region, because Asia versus Asia and rest of world, because as hepatitis B, C, and alcoholism varies, hence this stratification. Then performance status, PS 0 and 1 were taken. Then based on macrovascular invasion and extra hepatic spread, that was the also parameter. Then baseline AFP less than 400 and more than 400 was also a parameter. It is phase 3 trial, open label, randomized in 2:1 ratio in Atizo 1200 mg IV every 3 weekly, and bevacizumab 15 mg per kg every 3 weekly, compared with the at that time of standard of care, means standard of care sorafenib 400 mg BD, and it was continued till loss of benefit or toxicity. Then there were more around 20% were high risk patients. Co-primary endpoint was OS and PFS, and secondary end point was overall response rate. So in this baseline characteristic were well balanced, 336 patient in Atizo group, Atizo plus bevacizumab group, compared to 165 in sorafenib, as it was 2:1. And extra hepatic spread and macrovascular invasion was 77% in Atizo group compared to 120 in sorafenib group. And other group were almost comparable. So it has shown that Atizo plus bevacizumab has significantly improved the OS and PFS compared to sorafenib. In sorafenib group, it was 13.2 months compared to not reach in Atizo group, and PFS was 4.3 months in sorafenib compared to 6.8 months in Atizo group. And OS group, OS was also maintained, as we have seen in immunotherapy trial, that many patients this benefit was maintained, and median OS was 19.2 in Atizo group compared to 13.4 in sorafenib group, and it was significant. Then PFS was 6.9 months in Atizo group compared to 4.3 months in sorafenib group. In this curve across all the groups, this Atizo group has done better compared to sorafenib, except in BCLC stage B. Otherwise, in across all the group, Atizo plus Bevo was better. Regarding response rate was 27% in Atizo group compared to only 12% in sorafenib group. And CR, there was 6% around CR compared to 0 in sorafenib group. and median duration of response was 6.3 in sorafenib compared to not evaluated reaching atezo group. And then it was still associated with a higher overall response rate. In there were around 8% CR and 22% partial response compared to less than 1% CR and only 11% PR in sorafenib group. And median OS rate was also 67% in atezo group compared to 56% in sorafenib group. Regarding safety of all this drug compared to uh, sorafenib in patient with portal vein invasion, uh, that was in regarding proteinuria. Proteinuria was 34% in atezo plus bev group compared to around 30% in around 9% in sorafenib group. Hypertension was 23% compared to 9%. So median duration of response was more in atezo plus bev group. That's why I think side effects were also slightly different but comparable. All time of adverse effect was 98% compared to 99% in sorafenib group. Grade 3 side effects were 57% in atezo group compared to 55% in sorafenib group. Then uh, regarding safety profile, we have as our experience from sorafenib, it is very toxic drug. Hardly our patient tolerate full dose. So diarrhea was the most common side effect, and palmar plantar erythrodiosis was also more common in sorafenib group compared to in other atezo plus bev group. Proteinuria and ALT degree and pyrexia were more. And there were also immune related adverse effects due to atezolizumab. And then regarding there were this in this trial we have seen the risk of bleeding with in this is though cross trial comparison between IMBRAVE and reflect. In this we can see that uh, in Lenva group, there were patient with varices were excluded, and so median duration of response was in cross trial comparison better in atezo plus bev group, and grade 3, grade 4 toxicity were comparable in both the groups. Regarding bleeding event with systemic therapy was also lower compared to sorafenib in this group. And hepatitis was also in sorafenib group, it was 40% compared to 43% around in atezo group. So key aspect of in this group, patient were also assessed based on quality of life, functioning, physical and role, and symptoms, fatigue, pain, and other symptoms. So questionnaire completion rate was more than 93% and more than 80% until treatment discontinuation. So in both the groups, this has shown better QOL compared to sorafenib. Sorafenib median was only 3.6 months compared to 11.2 months in atezo group. And it also decreased the time from deterioration. So it was only 4.9 months in sorafenib compared to 13.1 in atezo group. And function also, it was 3.6 only compared to 9.1. So this is the NCCN guideline, which has clearly put atezo plus bev as category 1 recommendation, and now it is a standard of care for our patient. For unresectable BCLC stage C patient in first line, atezo plus bev is now first line due to this trial. So these are the various first line option. I have shown that Atizo plus Bev trial. Similarly, sorafenib and lenvatinib are also other first line drug. Second line we have sorafenib, lenvatinib, cabozantinib, rigora, and then Ansul has shown in third line now regorafenib also. So to conclude, Atizo plus Bev has demonstrated efficacy in unresectable HCC, and it has significantly improved OS and PFS compared to sorafenib, and it has also delayed the time from deterioration and good with good QOL and toxicity